Good evening, and thank you for joining us for this webinar from the National Lipid Association entitled Cardiovascular Patient Management in the Era of COVID-19. My name is Dave Dixon, and I'm an associate professor and the vice chair of clinical services at Virginia Commonwealth University School of Pharmacy. My colleagues and I have prepared this webinar to assist busy clinicians who are managing patients at high risk of cardiovascular disease who are more susceptible to the potential consequences of COVID-19. Before we get started this evening, we have two brief polling questions on the screen. So if you'll please address those first. Okay, thank you all so much for answering those. So let's jump right in. So to kick us off, I would like to welcome to our virtual stage Dr. Nihar Desai from the Yale School of Medicine section of Cardiovascular Medicine and the Center for Outcomes Research and Evaluation, who will discuss ASCVD as a risk factor for COVID-19 mortality.
Great. Thanks very much, Dave. And it's great to be with you. I hope everyone out there is safe and well. It's certainly been an uncertain and a challenging time, I think, but hopefully we are through the worst of it. And I hope you and your families and everyone has been well through this time. So I'm going to start off and as Dave kind of mentioned, just try and quickly set the stage for the impact of cardiovascular disease on COVID-19. I think it's fair to say what may have initially been built as a respiratory disease, I think there's been an emerging recognition of both the cardiovascular manifestations and the impact of existing cardiovascular disease on the morbidity and the mortality of patients who ultimately get this viral infection. These are my disclosures. So I think we'll start here, which is a recent analysis that was led by Mandeep Mehra and collaborators actually from around the world, an observational database from 169 hospitals across 3 continents and about 9,000 patients altogether. And you can see sort of in the table 1 here, just about 8,400 survivors and about 500 non-survivors, just trying to get a sense for what's the profile of the patients who ultimately succumb to COVID-19 versus, those who do not. And I think it's quite glaring that when you look at the coexisting conditions, you can see almost a twofold difference in the prevalence of coronary artery disease, kind of similar, almost threefold difference in the prevalence of congestive heart failure, and a nearly twofold increase in cardiac arrhythmia. There were similarly kind of a higher prevalence amongst non-survivors with COVID of diabetes, as well as hyperlipidemia. So I think it does kind of paint a picture of the fact that patients who get COVID and that also have other existing cardiovascular diseases, seem to do more poorly with this viral infection than those who did not have those comorbidities. Kind of in parallel, and I know many of the speakers are going to touch on this point, and so I just want to sort of look at it very quickly, high level, again, using the same database that we were just looking at, kind of looking at differences in the use of certain cardiovascular medications. And I know there's been a lot of discussion about this, and particularly around the ACE and the ARBs, and we're also going to have kind of a focused presentation on statins. But I think thus far, at least in these data, and I think other data that you will see as well, there doesn't seem to be any significant kind of association between use of ACE inhibitors or statins or other cardiovascular medications and having sort of adverse events with COVID-19. So certainly here, this slide kind of nicely highlights that. When you put all of this data together and you sort of look at the association of both clinical risk factors and medications on clinical outcomes, you can see that there are a couple of things that are on the right-hand side of the line of unity, suggesting an increase in the risk of death, if these factors are present, and those would be coronary disease, congestive heart failure, and arrhythmia. And then some things that actually, if anything, look to be somewhat protective. And those were receipt of an ACE inhibitor and receipt of statin therapy. Now, of course, the investigators were very careful to suggest that, this should not imply that people should be commencing therapy with these, should they have COVID, but certainly no sign for concern or an adverse signal with these commonly prescribed cardiovascular medications as well. So I think an important kind of safety issue that was addressed in this data set, and one that's obviously very relevant to our patients and our colleagues. I think two other kind of quick things just to touch on. So this is an analysis from NYU Langone, also published in the New England Journal a couple of weeks ago, looking at cardiovascular pharmacotherapy and COVID-19 outcomes. And while this analysis had over 12,000 patients, the investigators did a propensity matched sort of analysis. And again, just asking the question of whether there appeared to be any kind of association or signal for patients receiving ACE inhibitors or ARBs and having more severe COVID infections. And that was sort of obviously defined as death or use of invasive or mechanical ventilation or even admission to the intensive care unit. So even when you looked at a kind of a broader clinical endpoint of more severe COVID infection, there again did not seem to be any signal for for any adverse events with the use of these commonly prescribed cardiovascular therapeutics. And so with that, I'll sort of turn it back over to Dave.
Thank you, Dr. Desai. That was a great overview and really sets the stage for the rest of the evening. Now I'd like to welcome Dr. Anandita Agarwala Kulkarni, who is a fellow in the cardiovascular division at Barnes-Jewish Hospital, Washington University in St. Louis, to educate us on the expanding practice of telemedicine.
Thank you for that introduction, Dr. Dixon. Today I will talk to you about telemedicine in the era of COVID-19. I have no disclosures. We'll start out by addressing the question, what is telemedicine? Telemedicine encompasses real-time audio-video communication tools that connect physicians and patients, store and forward technologies that collect images and data to be transmitted and interpreted later, remote patient monitoring tools such as blood pressure monitors and wearable devices that can communicate biometric data, for example, the Apple Watch or the Fitbit, and verbal or audio only and virtual check-ins via patient portal and messaging technologies. The Centers for Medicare and Medicaid Services lifted Medicare restrictions on the use of telehealth services during the COVID-19 emergency. And with that, there are 6 key changes. Medicare will pay physicians for telehealth services at the same rate as in-person visits for all diagnoses. Patients can receive telehealth services in all areas of the country and in all settings, for example, at home. CMS will not enforce that patients have an established relationship with the physician providing telehealth. Physicians can reduce or waive cost sharing for telehealth visits. Physicians licensed in one state can provide services to Medicare beneficiaries in another state. However, state licensure laws will still apply. And finally, the Health and Human Services Office for Civil Rights offers temporary flexibility for telehealth via popular video chat applications such as FaceTime and Skype. It is important to note that these waivers are temporary and effective during the period of the national health crisis. There is no guarantee that the waivers will continue after the COVID-19 crisis. The waivers end at the termination of the telehealth period. For those of you who are using telemedicine or plan to use it, I want to emphasize the importance of keeping track of when this date may occur. There has already been some discussion in some states about ending the waiver soon. At the same time, telemedicine has been met with success in many venues and may be here to stay. Thus, it may be advantageous to set up a telehealth practice that incorporates the prior standards for telehealth to be prepared for those changes. Here are a few things to keep in mind. Separate entities make decisions on various aspects of telehealth. There are federal versus state regulations, and also CMS versus state-run Medicaid plans versus commercial payers and self-funded payers. Just because one payer allows something doesn't mean that all the payers will. Here are my 4 pearls for adopting telemedicine into practice. Be familiar with federal and state laws and regulations, for example, licensure and prescribing limitations. Stay up to date as these may change or be updated from time to time. Assess your technology and technical support needs, for example, peripheral devices like stethoscopes or otoscopes and data encryption. Choose a service model that works well for you and your patients, for example, providing direct patient care, triaging, or providing consultative services to other practitioners. And finally, understand and implement practice guidelines, including clinical practice guidelines and state and federal regulatory guidelines. There are 3 main types of visits that are covered by CMS. A virtual check-in pays professionals for brief 5 to 10-minute communications that mitigate the need for an in-person visit, whereas a visit furnished via Medicare telehealth is treated as the same as an in-person visit and can be billed using the code for that service, using the place of service 02 to indicate the service was performed via telehealth. An e-visit is when a beneficiary communicates with their doctors through online patient portals. It is important to inform patients about telemedicine, educate them and encourage them to use it. This has been met with tremendous success at our institution, and many patients have embraced the concept quite well. But there still may be some patients who are reluctant to use it. In my experience, it's convenient, both for the patient and the provider, efficient, and obviates the need for transportation, which is quite advantageous for patients with physical limitations or a limited ability to travel. Although COVID-19 is the most impending health emergency in most countries, cardiovascular disease remains the leading cause of death worldwide. Social distancing, staying at home, and telecommuting reduce exercise and levels of physical activity. And in fact, sedentary and screen time is skyrocketing. This is truly a time where we need to make the best of the situation and emphasize cardiovascular disease prevention. This is a figure that was recently published in Circulation that highlights the way in which we can promote cardiovascular health during COVID-19. There is a great role for patients, providers, healthcare authorities, and researchers to use telemedicine to their advantage to make big strides in prevention. Physicians and providers can emphasize healthy habits, physical activity, diet, exercise, assessing risk factors, and encouraging medication adherence. Patients have the opportunity to take ownership of their cardiovascular health and use health technologies such as fitness trackers. There's a lot of great information and data that can be gleaned from the use of some of these novel and repurposed technologies, which can truly change the way we practice medicine and approach prevention. And with that, I'm going to turn it back over to Dr. Dixon.
Thank you so much, Dr. Kulkarni. That was a great summary of telemedicine, and I think that certainly some shape or form of telemedicine is here to stay for sure. So I'm going to take the next 15 minutes and dive a little bit deeper into the ACE inhibitor, ARB, and NSAID controversy as it relates to COVID-19. And I have nothing to disclose. So we're all very familiar with the renin-angiotensin-aldosterone system, and it's important to note that the sort of actor that's getting the most attention lately is ACE2. ACE2 has only recently really been fully identified in 2002. And ACE2 essentially has a favorable effect on blood pressure by catalyzing the hydrolysis of angiotensin 2 into angiotensin 1 through 7. ACE2 does counter the activity of the related ACE, as you can see in the figure, by reducing the amount of angiotensin 2 and thus having an increase on angiotensin 1 through 7. So this kind of sets the stage for the discussion of how does this connect to SARS-CoV-2 and COVID-19? So if we look back at some other data, looking at other viruses, we know that ACE2, at least in mice, does appear to mediate influenza H7N9 virus-induced acute lung injury. Angiotensin II is upregulated after the downregulation of ACE2, then causing or contributing, we think, to the development of severe lung injury via the angiotensin 1 receptor. And so having this background, sort of set up the concern that there could be a similar mechanism, given that SARS-CoV-2 utilizes ACE2 as well. But if we look in the available data we have in humans, and we look at this meta-analysis of 37 studies, you can see that ACE inhibitor and ARB use is actually associated with a lower risk of developing pneumonia. So at least if we look back at the data we have in patients that are on these agents, it doesn't suggest that there would be an increased risk of developing pneumonia. But SARS-CoV-2 does use ACE2 to gain host entry. But it is important to note that once this occurs and the virus replicates, that ACE2 is actually downregulated. And this reduction of ACE2 during the infection can actually lead to a hyperactive angiotensin II. And we know that angiotensin II plays a huge role in causing or contributing to acute lung injury and other types of vascular complications and inflammation. So if we inhibit angiotensin II, either through ACE inhibition or ARB, there may actually be a reduction in inflammation and reduced risk of lung injury, which contradicts at least some of the initial concerns regarding the ACE2 mechanism and ACEs and ARBs. And I'll say that I'll say that there's certainly some conflicting information out there. If you look in the literature, we know that ACE2 is substantially increased in patients with diabetes. That's no big surprise, in those that are on an ACE or an ARB. We know hypertension, if you're treated with an ACE or an ARB, there is that upregulation of ACE2 that can occur. There's some contradictory evidence suggesting that the activity and action of ACE2 is not affected by ACE inhibitors. And there's actually a study with olmesartan showing that there is a significantly increased expression of ACE2. So again, if you look at the data out there, it's very contradictory and not clear cut, but by and large, there certainly must be or seem to be some effect on ACE2. Does this play into a clinical impact on one's ability to or susceptibility to developing COVID-19 infection? Does it lead to more severe disease? Those are the questions that continue to bubble up. We do have some emerging evidence. So this was a small study in 42 patients that were admitted with COVID-19, looking at various clinical, immunological, inflammatory, and viral findings, and at least suggest that those individuals who were not on an ACE or ARB seemed to do better. There was some reduction in CRP, IL-6 levels, but again, 42 patients, very small study. So in more recent weeks, we've gotten better data, and Dr. Desai's alluded to some of this, really looking at large cohorts of patients, looking to see, looking at those who were on an ACE or an ARB versus those that were not. This was some data from Central Hospital in Wuhan, China, showing no association with the severity or risk of death, specifically in patients with hypertension, thus suggesting no impact of ACE or ARB use. One of the more substantial studies was this case control study published from the Lombardy region of Italy, just over 6,000 cases compared to just over 30,000 controls. Looked at patients on various antihypertensive medications. I've highlighted the ACEs and ARBs there, and you can see really regardless of gender, age, and severity of clinical manifestations, there seems to be certainly no increased risk with ACE or ARB use. So is this question totally answered? Well, maybe not, right? It's always good to dig deeper. And I think that these ongoing clinical trials will be very informative. There's several going on with losartan in terms of the role of losartan potentially reducing the development and severity of disease. So we'll have to wait for this evidence to emerge. But I think as it stands right now, there's not a wide range of evidence suggesting potential harm. So as a result, various recommendations have come out from professional societies, including the American Heart Association, Heart Failure Society of America, American College of Cardiology, et cetera, really recommending that patients should continue taking ACEs and ARBs. The NIH panel that recently put out recommendations also do not recommend initiating ACEs and ARBs for the sole purpose of treating COVID. So, if a patient's enrolling in a clinical trial, that's different. If a patient's already on an ACE or an ARB, that's fine. But we certainly don't have evidence to show that ACEs and ARBs play a role in treatment or mitigating the severity of the disease. And so we have to wait for more data there. Really important note here, we really want to be careful in patients with heart failure, prior myocardial infarction. Abruptly withdrawing these therapies could certainly lead to clinical instability, increased risk for worsening heart failure, hospitalizations, et cetera. So I think that that's a really key point. So moving on to the NSAIDs controversy, and really this came about through Twitter, oddly enough. So the health minister from France, put out a tweet regarding anti-inflammatory drugs such as ibuprofen could be an aggravating factor and really pushing acetaminophen or similar products instead. Then there was a paper published, Are patients with hypertension and diabetes at increased risk for COVID-19 infection? And, I've read through this several times, and there's a statement there that alludes to not just ibuprofen, but even thiazolidinediones potentially increasing ACE2, getting back to that initial concern that if we increase ACE2, we may increase access for SARS-CoV-2 to infect someone. But I did find it interesting. There's really no substantial evidence. As you can see, there's a lack of a reference there really to support that. And at least in my own literature searches, trying to find that data that really shows NSAIDs have an effect on ACE2 is pretty difficult to find. We don't have a lot of great data here, but if we think about other types of viral infections, there's some data here looking at adult and pediatric critical care patients with influenza based on pre-admission use of NSAIDs or aspirin. And you can see here, with the risk ratios right around 1, really not suggesting any concern. In fact, there's even some data suggesting that indomethacin, at least in vitro, may have antiviral activity against SARS-CoV infection. Multiple mechanisms proposed. Obviously, this is very preliminary data, but certainly did not find that there were any harm. Parallel experiment in this study did not find aspirin to have any antiviral activity, but didn't show any other effects either. So, I think for sure, based on the evidence we have, that there's nothing overwhelming that NSAIDs should be avoided. Now, I think certainly I agree that the World Health Organization and the FDA, they've put out statements saying there's no evidence of worse outcomes. But, we know our patient population, and I think as a general rule, we still want to be careful with using NSAIDs in patients with cardiovascular disease, heart failure, kidney disease, for all of the reasons that we would normally try to avoid NSAIDs. So I think, we have to be careful from that standpoint. But in terms of NSAIDs having an adverse effect on COVID-19 itself, there does not seem to be a plethora of evidence to support that. So a few take-home points. There's certainly some conflicting evidence regarding the presence and significance of an interaction between ACE inhibitor, ARBs, and ACE2. Based on the evidence we do have and the number of studies that have come out, at least observational evidence shows that ACE and ARB use does not increase the risk of severe illness due to COVID-19. And again, no evidence supporting that NSAIDs have any adverse effect. But as a general rule of thumb, we want to continue to be mindful and careful about using NSAIDs in those patients that are at high risk of adverse effects from NSAID use. All right, so thanks for your attention there. I'm going to welcome back Dr. Desai, who will update us on the use of hydroxychloroquine in COVID-19, which is a consistently evolving area. So look forward to his thoughts on that.
Thanks again, Dave. Yeah, and it's I mean, as you think about all the different topics that we've kind of gone through, and through this whole COVID pandemic, I think the saga of hydroxychloroquine is certainly one that I think everyone's going to remember for quite some time. And so my hope is to just kind of give people an overview of kind of where we started, kind of where we've come, maybe where we are right now, and then what some of the additional kind of outstanding questions are. So I think where we are is probably here. I think there's been a reappraisal of hydroxychloroquine, and I think there has been lots of coverage in the lay media just as much as in kind of the medical literature around hydroxychloroquine. And I think it's fair to say that there was a lot of hope for this therapy, early on. And I think both in the scientific community and in other places, I think we were all kind of hearing that, hydroxychloroquine may be an effective therapy for COVID-19. I think, when you look at the data that we have, and I'm going to show some of it, and as, Dave was alluding to, there seems to be, every day additional data or new studies or analyses kind of coming out around these different therapeutic agents. These are some data from New York Presbyterian and the Columbia hospital system. And what is shown here is sort of the association between hydroxychloroquine use and kind of, again, a broad clinical endpoint of intubation and death. And what you can see as you kind of walk through this this table is in the unadjusted or the crude analysis, kind of in the middle row of this table, there was actually a hazard of hydroxychloroquine use and that composite endpoint. In fact, about a 2.5-fold increased risk. Now, it turns out when the investigators did a number of additional analyses, they do multivariable analysis or they do propensity score matching, actually using a number of different analytic tools, it looks like that kind of hazard goes away, but there certainly doesn't seem to be any benefit. So you see kind of odds ratios there, right around 1.0, down to 0.97, but with wide confidence intervals that do indeed straddle the line of unity of 1.0. And so, this was one analysis, again, from a couple of weeks ago, showing no real benefit to hydroxychloroquine use. I think the other comes here. Again, this is US-based data. This is from JAMA, about a week or 10 days ago now, looking at the association of hydroxychloroquine with or without azithromycin. I think that was a cocktail that many hospitals were using, the addition of the macrolide antibiotic to the hydroxychloroquine. And this is using pooled data from New York State. And what you can see kind of in the event curves is the hydroxychloroquine, azithromycin, hydroxychloroquine alone in the orange, the azithro alone in kind of the sky blue, and then neither in kind of the gray. And I think as you look to the table down below, and you look again at the adjusted risk of death or cardiac arrest and arrhythmia, which is another topic that we'll kind of talk about. So maybe for now, we'll just focus on in-hospital death, which is the top row. And if you look at the first couple of columns there, the first column being combination therapy, hydroxychloroquine with azithromycin versus neither, certainly no signal for a benefit with a ratio there of 1.35. And then if you look in the next column over, that's hydroxychloroquine alone versus nothing. And again, doesn't really seem to be any sign of benefit there either. And so again, this I've just shown kind of two pieces of data. There's obviously been a VA study that's gotten a lot of attention. I didn't sort of show that here. And I think the other sort of key point that I would just note in terms of hydroxychloroquine, azithromycin, and clinical outcomes is there was an analysis released just today in The Lancet, led again by Mandeep Mehra, with that same kind of analytic cohort that we talked about on kind of, my first slide, the observational database from, 169 countries and 3 continents, where they, again, not only did they show no benefit with hydroxychloroquine, but they actually showed a potential signal for harm, with hydroxychloroquine. So I think the picture has kind of come together in terms of hydroxychloroquine in the hospitalized patient with COVID-19 doesn't really seem to have, efficacy. There may, in fact, be some sign, of harm, at least in this most recent paper, from that group, kind of that international consortium, if you will. And I think the other element that's worth thinking about for hydroxychloroquine is we know that there is QTC prolongation that can happen with this drug, and so I think it's worth just touching on that for a moment. And so these are data from a group in Boston at the Beth Israel Deaconess, published in JAMA Cardiology. And on the left, you can see patients that were treated with hydroxychloroquine, kind of a baseline QTC and then a peak QTC shown on the panel here. And then in the right-hand panel, combination therapy of hydroxychloroquine with azithromycin. And the overall kind of takeaway here was that you had somewhere right around 20% of patients, who got hydroxychloroquine alone or combination therapy who wound up with significant QTC prolongation, namely with a corrected QT interval greater than 500 milliseconds. Now, it's been quite interesting to note that both in this study and in several of the other published studies that have looked at QT prolongation, the rate of torsades or other malignant arrhythmias has been quite low, and thankfully so. There was some initial kind of conflicting evidence around that, particularly from international data sets, but it looks like the US data shows that there does seem to be an increase in the QT interval, but the risk then of torsades or other malignant arrhythmias seems to be, thankfully on the low side. So just something to consider as you kind of continue to hear and read about hydroxychloroquine. That said, I think it's important to note that it's still sort of an open question. I know there's, a lot kind of still happening with hydroxychloroquine in the news, but it is important that just as of, 8 days ago, the National Institutes of Health began a clinical trial of hydroxychloroquine and the macrolide antibiotic azithromycin to treat COVID. Importantly, this is a study that's enrolling adults with mild to moderate COVID-19, so kind of a different population than the data sets that have kind of looked at this question thus far, which were primarily, hospitalized patients with at least moderate to severe infection. And so, I think it is sort of an open question, and so obviously this data will then be, provide us some further clarification on this. And so, just kind of a couple of takeaways from my 2 segments before I kind of, turn it back over to Dr. Dixon is, that not only is there a growing recognition of the cardiovascular manifestations of COVID-19, but also a growing appreciation of the serious consequences of COVID-19 in patients with cardiovascular disease. And I think, both I and Dr. Dixon in his presentation, I think kind of reviewed the data for that. Second, at this point, there really doesn't appear to be a significant concern regarding the use of ACE inhibitors or ARBs. And I think, again, Dave and I, reviewed that, and Dave very nicely kind of highlighted what the professional societies have kind of said around this. With hydroxychloroquine, either with or without azithromycin, doesn't appear to meaningfully mitigate the risk of adverse events in hospitalized patients with COVID-19. But its role in individuals with more mild or moderate disease remains unclear. And I think that NIH-sponsored trial will then, I think, bring some clarity to that. So thanks again for your attention, and I'll turn it back over to Dave.
Thank you, Dr. Desai. For our final lecture on the role of statin therapy, I'm pleased to welcome Dr. Sudha Ravilla, who is the medical director of the Lipid Clinic at Tallahassee Memorial Metabolic Health Center. Please stay with us once she finishes up. We will put our polling questions back up, and then we'll jump into Q&A from the audience. Welcome, Dr. Ravilla.
Hello, everyone. Thank you, Dr. Dixon. First of all, I want to thank the National Lipid Association for inviting me and giving me this opportunity to discuss this topic in such a timely manner. I do have a disclaimer, rather warning. I'm going to be going very fast because of the breadth of topics that I have to cover, but I believe the slides will be available for your review later. I'm going to try and give you a bird's eye view of my journey of research into this topic, which I found truly fascinating. We're going to start out with a picture. They say a picture is worth 1,000 words. What you're seeing here is a very sad depiction of a bunch of kids in a village in Alaska who were orphaned by the 1918 pandemic. And what you're also seeing is a conspicuous absence of their young parents. So I sort of juxtaposed the mortality curve right next to it for context. Now, we're used to seeing the U-shaped curve as we're seeing with the inter-pandemic period here, with the extremes of age groups being more vulnerable to death. But a strange phenomenon happened during the 1918 pandemic. This little blip that you see actually represents the fact that young people died at an alarmingly high rate during this pandemic. Now, there's been multiple speculations in the scientific world about why this might have been, but I think one common consensus is that this might have been due to a dysregulated host response scenario, meaning an exuberant host response and overzealous host response. So that sort of sets the stage for our discussion today, because we're going to be focusing on the host response side of the equation. With delays in vaccine development and antiviral agents, of course, we have a dire need to use drugs that are already available, that can be repurposed, cost, efficacy, and safety being sort of the cardinal aspects of therapeutic agents in pandemics. So why statins? Why not statins is really the big question. Statins have been studied in pneumonia, lung injury, ARDS, sepsis, of course, cardiac injury, as you all know. But I'm just going to walk you through these areas of research and data available. We're going to start out with lung injury. Now, the basic injury pattern at the molecular level, we're going to take the example of lipopolysaccharide in the slide, but from a bacterial pathogen, but this could well be a virus that stimulates pulmonary macrophages, which leads to reactive oxygen species production, which can lead to widespread cell death, which then triggers the release of oxidized phospholipids. Now, oxidized phospholipids seem to be very potent triggers for the TLR4 MYD88 pathway. Now, TLR4s are pattern recognition receptors, as you all know, but there's different kinds of sort of subtypes of TLR4 receptors, or TLR receptors rather, and they seem to have a differential affinity for being triggered by various pathogenic motifs, if you will. And they also seem to have a differential tendency to trigger downstream pathways as well. MYD88, myeloid differentiation primary response, 88, say that once, seems to be one of those adaptive proteins that they like to use. Most of them like to use it. The TLR3 is an exception. Regardless, MYD88 ultimately lands on the nuclear factor kappa beta pathway, sort of the mother flagship pathway, that leads then to a cytokine storm. Now, as you all know, NFKB is basically a family of nuclear transcription factors that can be induced, and then in turn this can induce or upregulate expression of multiple pro-inflammatory genes such as interleukin-6, as well as chemokines and even inflammasomes, leading to acute lung injury. Now, statins have a very favorable effect on these pro-inflammatory molecules, as you can see, directionally very favorable, with the exception of heme oxygenase, which happens to be a protective enzyme that inhibits reactive oxygen species. So how do statins accomplish this? Well, it appears that a big chunk of the broad immunomodulatory effects that statins have seem to emanate from their capacity to block mevalonate production. Now, think of mevalonate as sort of the mother molecule of isoprenoid molecules, farnesyl pyrophosphate, geranol pyrophosphate. These are basically, hydrocarbon isoprenoid lipid molecules that typically have to sort of attach themselves to subcellular groups of proteins such as RAS and Rho and RAC as an example. This is sort of a prerequisite that these isoprenyl molecules isoprenylate these GTP proteins and cause post-translational modification of these proteins, so then they can bring about their effector functions such as proliferation in this case with RAS, reactive oxygen species production with RAC, and a Rho, of course, further triggering NFKB and also triggering the coagulation cascade. As you can see, though, just by inhibiting mevalonate, statins can have quite the latitude of effect on an anti-inflammatory milieu. So let's move on to some clinical data. Statins and community-acquired pneumonia. Well, at the outset, I have to tell you the data is very, very mixed. Positive, negative, positive, negative. But I chose a couple studies just to bring out the big picture. There was a meta-analysis of 13 studies of over 250,000 patients with community-acquired pneumonia where treatment with statins improved survival. But prior statin users in the community had the most benefit in terms of survival. This was actually backed by experimental data that showed that pre-treatment with simvastatin attenuated the inflammatory response to lipopolysaccharide in healthy human subjects, meaning this was a human trial. So essentially they gave healthy human volunteers lipopolysaccharide, made them inhale it, and they collected the pulmonary macrophages, and they actually looked for NFKB levels and activity, and those that were pre-treated with simvastatin had much lower levels, which is pretty fascinating. But even more fascinating was a study from 2019. I want to say this is probably one of the best showcases of translational medicine, which combined sort of rudimentary bench research with a sophisticated randomized control trial setting. And what's even better, they chose older patients. The mean age was 78. This is a group, as you know, is pretty remarkably neglected in clinical trials. So they chose older patients with community-acquired pneumonia and sepsis in the non-ICU setting, mind you, and they used high-dose simvastatin, believe it or not, 80 milligrams. They explored the ability of statins to improve neutrophil function. The primary endpoint really was a concept called netosis. Now, I was new to this, and I wanted to share this with you. It's pretty fascinating. It stands for neutrophil extracellular trapping function. As you can see, these chromatin fibers here put out by the neutrophils tend to trap pathogens. Could be bacteria, virus, protozoa, etc. Now, it was detected that simvastatin had a very moderate effect of mildly downregulating the netosis, meaning too little netosis, as you can imagine, can impair pathogen clearance, and too much netosis can cause host injury. So simvastatin seemed to do just the right amount of reduction. And in a post-hoc analysis, hospital-free survival improved, and of course, overall it was safe. Generally who did well? Older patients, milder disease, high-dose statins, treatment started early. So just keep this in mind because this theme will repeat itself over and over again. And I do want to point out again, this netosis is probably something you're going to be seeing in the literature more. There was a paper a few weeks ago in a Cell journal that actually talked about this being linked to microvascular thrombosis, these chromatin fibers sort of offering scaffolding for microvascular clots in COVID-19. So stay tuned. Statins and ventilator-associated pneumonia, well, mixed studies again. There was a positive study with pravastatin, which reduced VAP frequency. Negative with simvastatin, already established VAP. Overall, safety data was positive. What's the takeaway? Observational studies tend to be positive. RCT is negative. Keep in mind, RCTs were done in heterogeneous clinical phenotypes, which may explain the discordance. Overall, de novo versus continued, which fares better? The answer really depends on type of population, severity of illness, type of statin, dose, duration, timing. Well, we're going to move on to ARDS. ARDS, as you all know, is a heterogeneous spectrum. As much as we think we know, it's as complex as probably sepsis. And it is characterized by acute hypoxemic respiratory failure. If you think about the immunopathology, neutrophils and alveolar macrophages seem to sort of set the stage with cytokine storm, and lymphocytes and fibroblasts, of course, finish up the job. And what about the role of statins in ARDS? As we just discussed, with inhibition of mevalonate pathway, they have quite the broad benefits. But in addition to that, statins can also induce endothelial nitric oxide synthase expression, which is very important for endothelial health in general. Endothelial dysfunction is central to acute lung injury. This is important to understand. We tend to associate endothelial dysfunction with the cardiovascular realm, but if you think about it, pulmonary, endothelial surface reflects, I believe, 25% of the entire vascular surface. So, and not only that, there's probably a subset of patients with acute lung injury and ARDS in whom endothelial dysfunction plays a major role in their disease process. Once again, probably that subtype might respond the best to statins. But again, in the interest of time, I'm going to go over maybe one other action of statins, that they can inhibit matrix metalloproteinase, which can aid in alveolar epithelial barrier function, which, as you can imagine, would be quite protective in a hyperpermeable exudative pulmonary edema type situation in ARDS by improving alveolar basement membrane integrity. What about statins' ability to upregulate ACE2? They actually seem to do this via epigenetic histone modification. Pretty intriguing. Obviously, this can be very beneficial in SARS-CoV-2 virus infections because they tend to downregulate ACE2. So keep that in mind. What about statins and ARDS clinical studies? Well, 2 negative RCT trials, one with simvastatin 80, ARDS of any cause, called HARP2. There was another called SAILS, rosuvastatin 20, and ARDS from sepsis. But a subgroup analysis showed risk reduction in the hyperinflammatory phenotype. Now, in the same breath, I'm going to say retrospective analysis of SAILS study also showed statin group had a rise in interleukin 18 levels, which tracked with mortality. Now, how do we reconcile the two? For one thing, they're both retrospective analyses, but I think it's also important to understand that maybe when we look at particular subtypes, well-chosen phenotypes, we might see accurate results. So phenotype biomarker-dependent treatment response is possible. The concept of predictive enrichment strategies, this may help design RCTs in the future. It's much like our risk refinement, risk enhancement, in the cardiovascular realm, if you think about it. So basically selecting for populations that would sort of have the best response to a therapeutic agent. What's the takeaway? Really, most people say game over to RCT trials, but I think there is hope. Again, precision medicine is probably the way to go. Choosing the right clinical and biomarker or biologic phenotypes really to formulate RCTs in the right populations. Moving on to sepsis. Infection-induced inflammatory syndrome, which is characterized by an amplified and aberrant host response. As you all very well know, sepsis is mediated by multiple cell types. Endothelium, once activated, can play a major role in microvascular occlusion, coagulopathy through tissue factor, PI1, neutrophils and monocytes contributing to cytokine production galore. In addition, monocytes can also, of course, trigger complement and lead to a multi-organ failure. Now, we do need to spend a second on the slide because this is a molecular mechanism that seems to be unique to coronaviruses. Once again, we're talking about SARS-CoV, MERS, and potentially COVID-2, which seems to share about 82% of the nucleotide sequence with SARS-CoV-1. Now, TLR3 and TLR4 have been found to be protective against coronaviruses. Now, you're going to think we just talked about TLR4, MYD88 being the major pathway in lung injury. And now we're saying they're protective. Now, how do we reconcile the two? Well, it's pretty self-explanatory, actually. What we're saying is we need an optimal dosing of this pathway. Very little of this pathway might lead to sort of a weak innate immune response that might not clear the virus or pathogen like it should. And a too robust of a response can then lead to lung injury or tissue injury. So as we said, most of these toll-like receptors like to use MYD88, and MYD88 signaling from whatever trigger can ultimately lead to NF-κB stimulation. And what's really fascinating is MYD88 has been shown to be induced by SARS-CoV. So too much MYD88 or too little, both can increase mortality. What's even more intriguing is statins happen to be MYD88 antagonists. Let me explain. It appears that statins don't necessarily downregulate MYD88, but they stabilize MYD88 under hypoxic conditions, not normal conditions, but hypoxic conditions. And there's also another in vitro study that looked at the role of statins in inhibiting NF-κB via MYD88 pathway, and atorvastatin 40 milligrams did a pretty decent job of that. I did note that some academic centers have sort of incorporated atorva 40 in their protocol for treating COVID-19 patients, and I wonder if this mechanism is what sort of drove them to do that. Interesting. Statins and sepsis, what's the clinical trial evidence? Well, there was a major trial called the ANSTATIN trial. So it was multi-center based in Australia and New Zealand. They actually pre-stratified people by prior statin use, which was smart. Atorvastatin 20. The primary outcome was interleukin-6 levels, and secondary was 28-day mortality. Results were negative, of course, but, the big but again, the subgroup of prior statin users had lower interleukin-6 levels going in, and they had improved survival as well. Once again, the right subgroup, probably right results. A sepsis trial. This was a randomized controlled trial as well. Atorvastatin 40 in statin-naive patients. It did reduce progression to severe sepsis, cut down the conversion rate to severe sepsis, and the number needed to treat was almost 5 in the study. Was very positive. Now, I threw this study in only because, even though it's a population-based study, because the sheer number of patients that were looked at, 1 million patients. This was done in Taiwan, I believe. They looked at their national health database, and they followed 50,000 patients longitudinally. And the primary outcome was that simvastatin and atorvastatin lowered 30-day mortality in sepsis, while rosuvastatin did not. For what it's worth, I did want to throw in another study for your information. There was a study looking at comparing simvastatin, atorvastatin, and rosuvastatin, looking at their minimal inhibitory concentrations in a petri dish against bacteria, and it was found that simvastatin and atorvastatin fared better than rosuvastatin. Food for thought. Maybe lipophilic statins do better in a sepsis infection scenario. Takeaway, once again, observational studies, even though quite positive, we do have to remember and not overlook the concept of healthy user bias, meaning statin users probably had the will and means to access healthcare, therefore started out with a healthier baseline, fewer comorbidities, and therefore biasing the study towards the positive side. Safety was reassuring. RCTs and meta-analyses were largely null or negative. Again, safety was reassuring. Again, what we need is large prospective randomized controlled trials using very sharp and well-defined clinical and biological phenotypes, even if the sample size is small. Continuation seems safe, potentially beneficial. Discontinuation seems to track with worse outcomes. We're going to move on to viral infections of the cardiovascular system. This audience need not to be lectured on this topic, but I did want to mention that there are some trickling reports about the possibility of direct endothelialitis and ACE2 receptors being expressed in endothelial cells. Again, early stages, but I think the big chunk of the injury to the heart is coming from the cytokine storm, sympathetic stimulation, hypercoagulability. Once again, cytokine storm, sympathetic stimulation being major risk factors for heart failure, much the same for arrhythmias as well. If you look at the presentation patterns of myocardial injury in COVID-19 in particular, we're seeing a lot of troponin elevations, of course related to ischemia, but also associated with elevations in D-dimer, ferritin, interleukin-6, and LDH, representing the cytokine storm. And they could also present with a classic viral myocarditis picture, or less commonly, fulminant myocarditis, although this is being reported. If you look at the histology, you see an interstitial mononuclear lymphocytic infiltrate. I threw these two histopathology specimens just so you can appreciate the difference in histopathology as well as presentation, as well as prognosis with lymphocytic myocarditis. I believe this was a Chinese gentleman, very little infiltration. He did not make it. This was an Italian lady in her 40s, presented with sort of classic myocarditis. As you can see, pretty rampant lymphocytic infiltration. She did well. So sort of a very variable trajectory. And generally, though, lymphocytic myocarditis seems to do fare better compared to giant cell or other nonspecific myocarditis. But again, I have to mention, I don't think we have great evidence that there is direct infiltration by the virus yet. We're seeing some sparse reports here and there. So there is more that needs to be understood about SARS-CoV-2 in terms of it being a cardiotropic virus as such. But we're watching. It is important to remember, though, myocardial injury is a key prognostic factor in COVID-19. As far as immunopathology goes, if you look at experimental animal models, there seems to be an acute phase where there is potential direct injury to cardiomyocytes from viral replication, a subacute phase with the T-cell immune response to myocyte injury, and of course a chronic phase with myocardial repair, remodeling, leading to dilated cardiomyopathy. It is important to remember that in the last few years, we've learned that Th1 and Th17, sort of subset of helper T cells, might be key players in the immunopathogenesis in myocarditis. How do statins help? Well, statins actually do a pretty good job of modulating T cell function. They can inhibit T cell activation, cell proliferation. They also seem to dampen the Th1, Th17 polarization. I will show you in a second. There was a study with pitavastatin. They also reduce crosstalk with antigen-presenting cells in the context of molecular mimicry that can reduce the incidence of autoimmune myocarditis. They can also inhibit myocyte apoptosis. Well, this is a really good summary. Please take a look when you get a chance. As you can see, I did an asymmetric job of copying and pasting here because I wanted to club up the lipophilic statins together to show you that in the last 16 years, almost every single year, there has been a study in animal models looking at the role of statins in improving cardiac structure, function, histopathology. And more importantly, these studies have also demonstrated the putative immunologic mechanisms by which statins can be beneficial. Pretty remarkable in the consistency of results. And like I mentioned with pitavastatin, this study came out in 2013, it seems to inhibit T cell differentiation into Th1, Th17, which I thought was pretty fascinating also. What about clinical studies? Well, unfortunately, no major dedicated clinical trials. There's one small study in biopsy-proven lymphocytic myocarditis, an ejection fraction less than 40%. Atorvastatin 40 seemed to improve ejection fraction. But the American Heart Association, as you all know, came out with a scientific statement a couple of months ago in JACC with regards to fulminant myocarditis and sort of soberly admitted to the dearth of data in this area. I think this also reflects how we struggle with the role of statins in heart failure patients as well. But again, I think it highlights the importance of potentially choosing the right subpopulation, the right clinical phenotype with the right biomarkers and the right biologic phenotypes that would respond best to statins. This is really a summary slide. Why not statins? They provide lung protection, cardiovascular protection, low cost, safety, availability. In addition to their myriad subcellular protective functions, as we said, statins can upregulate ACE. As you can see, the virus likes to utilize ACE2 receptor to make its ominous trek into the cell and seems to want to turn around and inhibit the ACE2 receptor, and statins can put a damper on that. We just discussed statins' ability to stabilize MYD88, inhibit NFKB, and not to mention, there is this cushiony collateral benefit of statins lowering LDL, which probably made you forget during the course of this talk. LDL that can be raised by antivirals and immunosuppressives, and statins can come in handy. Well, final takeaway, reasonable and potentially beneficial to continue statin therapy. What about de novo? Well, we do need to have more RCTs for definitive answers, like we discussed, in clinically and biologically classified phenotypes. But reasonable to start, there is a pre-existing guideline-based indication, of course, early in the disease process in patients with good hepatic and renal reserve, where the risk of harm is low. Because overall there were no major safety concerns in clinical trials, but I think it is important to monitor CK and transaminases and be acutely aware of the risks of rhabdo and liver injury in these critically ill patients. Discontinuation, sort of an oxymoron, not a good choice. Given the cardiovascular comorbidity in this population, of course, stopping can lead to worse outcomes in sepsis, but also in ACS and stroke conditions. So finally, not to end on a pessimistic note, but pragmatically, we do need to have some protocols at the very least that can be applied globally, and this certainly has implications in developing countries as well, given the wide availability and cost profile of statins. This is me thinking out loud. Explore IV statins. Why not? As I was researching this topic, the first paper that came up, I have to share with you, is a paper from JACC that looked at a pig model. This was a study from Spain that used IV atorvastatin during an MI versus oral atorvastatin post-MI, remarkable results in terms of a reduction in infarct size, scar size, remodeling, and even sort of favorably influencing the ischemia reperfusion sort of paradigm pathways. So fascinating. And I think I think about 12 years ago, there was another animal study in the acute ischemic stroke setting looking at IV statins again. So maybe time for human trials. Lastly, maybe we should consider adding a section for statins and viral pandemics in future guidelines. Thank you very much for your attention, and I think I'll turn it over at this point. Thanks, bye.
All right. Thank you so much, Dr. Ravilla. That was a fascinating discussion of statins and their potential role in not just COVID-19, but just in viruses in general. So I'm sure we'll have some questions for that. So as you all know, this is a constantly evolving area, and we had a couple of clinically related pearls that we did want to make sure that we touched on. So I'm going to touch on those real quick, and then we'll go on from there and wrap up. So certainly, for severe patients that are having to be sedated for extended periods of time, something that some lipidologists are getting consulted about is the propofol infusion syndrome. So propofol is a sedative hypnotic medication, obviously used as an induction agent for preoperative sedation prior to endotracheal intubation and other procedures. But due to its effects on the beta oxidation of fatty acids, these fatty acids can accumulate in various organs, such as the liver. And while propofol infusion syndrome is certainly rare, it can be quite serious and lead to multi-organ system failure. As I'm sure most of you know, hypertriglyceridemia is a common side effect of propofol and has been shown to be a predictor of propofol infusion syndrome. So, while certainly we don't have any real evidence in the setting of COVID-19, but just some general pointers, certainly with this, starting with prevention is the most important thing. Ideally with propofol, we like to limit the duration of use as well as the dose, since propofol infusion syndrome is certainly related to both duration of use and dose. That can be challenging since some of these COVID patients have to be sedated for extended periods of time. Obviously, if we can use alternatives, that's great. There's a list of those provided. Each of those has to be considered on an individual basis. There's not a single substitute for propofol, but we did want to touch on this since some of you may be getting questions about this particular issue. And lastly, so hydroxychloroquine has certainly received a lot of attention, but in more recent weeks, there's been more news regarding remdesivir, which is an antiviral agent that was initially investigated for its activity against Ebola, and it was only shown to be modestly effective. Wasn't really considered a mainstay of treatment. But it has been shown in vitro to have activity against coronaviruses, hence the interest in COVID-19. This antiviral therapy basically disrupts the machinery that the virus uses to replicate itself. The dosing is provided there. We do have limited data on drug-drug interactions, but the prodrug is metabolized by CYP3A4. But as of right now, and if you look at the various study protocols for the clinical trials that are ongoing, there are no dose adjustments or major concerns there. I do want to highlight on some of the evidence. So one of the first papers that came out in 237 severe COVID-19 patients actually found no difference in time to clinical improvement, found no effect on viral load, which is very surprising. They did find, however, that those who had received earlier treatment within 10 days of symptoms starting did seem to do well. And again, that was a placebo-controlled study. More recently, much larger trial, the NIAID's trial did meet its primary endpoint of time to recovery And this was a trial in just over 1,000 patients. And you can see that those that received remdesivir recovered in 11 days compared to 15 days in the placebo group. And there was a reduction in mortality there with a p-value of 0.059. And actually, just as of this evening, this paper was published in the New England Journal of Medicine. So I will point you all there to dig deeper. Then last note there, so this trial was stopped early due to these positive findings and the need to identify effective therapies for COVID, and did receive an emergency use authorization by the FDA on May 1st. So we wanted to make sure we touched on those couple of items. So now we will move on to our polling. And so if you will all take a moment to address the polling questions, and I'm going to review your questions that you've asked, and we'll jump into the question and answer session. Okay. All right. So why don't we move on to our first question? So Dr. Desai, I'm going to throw this one to you. So someone asked about the use of hydroxychloroquine in patients with mild COVID-19 and its potential role for use in the outpatient setting.
Yeah, Dave, it's a great question. And it's certainly one area that continues to kind of be in that, where there is kind of an evidence gap. And so, most of the data that we've shown and most of what you've heard about hydroxychloroquine has been, again, in the hospitalized patients, probably with more, severe disease. And so there is that NIH study kind of more in the mild to moderate severity COVID. And then the question around, kind of on the ambulatory side is, certainly, interesting to investigate there, with the data that we saw thus far. Granted, in hospitalized patients, we saw the QT prolongation at about 20%. And so you'd have to kind of develop an infrastructure for kind of monitoring that. Should it be used on the ambulatory side, at least after the first couple of doses, I think, just to reassure yourself. But I think that's very much an open question. I think, are there tools or strategies to try and mitigate disease burden, time course of disease, and obviously disease progression at the earlier stages or in the more mild forms? I think that remains to be seen. I think there's a lot of interest there, whether that's hydroxychloroquine, whether that's even some of the other immunomodulators, remdesivir, as well as others that that you heard about, statins and other therapies. So I think it's a very interesting question. I don't think we have an answer yet. But I suspect that we will get some emerging data kind of on that front. Okay,
great. Dr. Ravilla, I'm going to pose this one to you. So you talked a lot about statins, the potential anti-inflammatory effects. So there's a couple questions coming in regarding the potential role of therapies such as colchicine, canakinumab, and maybe even icosapent ethyl. So have you seen anything related to those trials or any thoughts regarding the use of those therapies and their potential in COVID-19?
All right. So, yeah, actually, they have, as you all know, colchicine has been studied in a clinical trial and in post-MI setting, I believe. And it actually was a positive trial. And I believe I want to say it didn't quite meet the primary endpoint, but there was a reduction, and if I'm not wrong, in strokes and revascularization, I think. So, yeah, it was a positive trial. I think that the concern with colchicine was pneumonias, the risk of pneumonias and, GI side effects. So there was another trial with just, along those lines with methotrexate. I believe it was called the CIRT trial, CIRT trial. And that was negative. And I think the argument with that study was they used low dose methotrexate. And I think the concern was it probably didn't lower the inflammatory markers especially, CRP and IL-6 as much as, we would have liked to in order to see an impact. So, yeah, I mean, again, as far as the canakinumab trial goes, I think it's pretty common knowledge. It did pretty well. I believe there was like a 15% relative risk reduction. And again, it kind of targeted interleukin 1B. And it was a positive study, sort of a pure, it was a study that looked at statins independent of its lipid lowering effects. And it was positive, but I think it was the cost was an issue, and infection, I think related sepsis, of course, that was an issue. So I think that goes to show this is a very complex issue, and you can't just look at one pathway, be it ARDS, be it sepsis, be it lung injury. There is such redundancy and overlapping with these pathways. So there is more to be understood about these heterogeneous disorders, before we can target singular pathways, I think. But overall, I think, along with statins, and statins, of course, with their anti-inflammatory pleiotropic drugs, I think they're very versatile in that we get the additional benefit of LDL lowering as well, which also makes it very difficult to tease out which one benefited the most. But I think the question, maybe the question is about anti-inflammatory benefits of other drugs, and they have been shown to be positive. So.
Great. And just to add to that, there's certainly a number of clinical trials ongoing with IL-6 inhibitors, canakinumab, really focused on that patient that is having the sort of pro-inflammatory response. So certainly a lot to be learned there, and we'll await those clinical trials. Question for Dr. Agarwala. So in your experience, how have patients responded to this transition to telemedicine, remote patient monitoring? I could certainly sense some patients adopt it quite readily. Maybe some are a little bit hesitant. If you could give us a little bit about your experience, that would be great.
I think it's been about a 50-50 split. I think there has been a good number of patients who really jumped right on with the telemedicine aspects. It's certainly convenient. And then there are a few that have been a little weary about the technological aspects of it. So I think it's going to take some time to really settle in, and we really have to encourage our patients to, make use of this great tool.
Yeah, I agree. I think that's certainly been my own experience. And Dr. Ravilla, Dr. Desai, if you've had some experience with that, feel free to chime in.
Can I go, Dr. Desai?
Sure, go ahead.
Okay. No, I just wanted to say I've actually had a very positive experience with telemedicine, as a lipid, purely dedicated lipid clinic. And I think, the advantage, since this is a purely sort of preventative field, I think this is a great opportunity for us to sort of keep people out of the hospital and, really optimize cardiovascular risk in the big context of things. I think, as lipidologists and, with of course physicians with special interest in lipidology, I think we play a major role, given the cardiovascular comorbidities and just the poor prognosis in COVID patients with cardiovascular comorbidities. We have, I think it's very, very actually applicable to our field to be using telemedicine. I've had great success. So I agree with Dr. Agarwala. I think it's we need to learn, the kinks better and, learn the ropes better and go along. But I think overall it's been very positive experience for me. So.
Yeah, Dave, I might just add that I largely agree. I mean, I think we have great success with telemedicine. I think our system, transitioned very quickly. I think we've all surprised ourselves at how quickly, we could sort of have a transition like this, and that going forward, telemedicine, as I think others have said, is here to stay. I do think that, one kind of cautionary note is, despite all the anecdotes about, how well it's gone and how well it seems to work, I do think it's an area that is kind of needs some comparative effectiveness research. I mean, I think, are outcomes similar? Is the patient's experience, just as good? What are the outcomes of these patients like? And I think just as importantly, are there potential disparities? I mean, how are these technological platforms kind of distributed across the various kind of communities and patients that we serve, and just to make sure that there aren't, any unintended consequences or potential blind spots with this transition. I think those are areas that I think very much deserve some focus and some additional study.
That's a terrific point, and I certainly agree with that. And I think this would be a great place to wrap up. First, I'd like to thank Drs. Agarwala, Dr. Ravilla, and Dr. Desai for their time this evening and their expertise. And I'd like to thank our attendees for participating and joining us. Be sure to check out lipid.org for additional educational activities like this. If you have any questions or any feedback, please send us an email at info@lipid.org. I hope everyone enjoys the long weekend and have a good evening. Thank you.